All right, thank you, Becky. Welcome, everybody. Glad to have you here. As Becky said, I am presenting a follow-up to something that we talked about 3 months ago. It's a project that we've been working on here at Oaklawn for, probably almost a year and a half now, but we're now underway, and Phil Good-Elliott is joining us this time around. Phil is actually the clinical social worker who is doing the clinical work in our primary care setting. Our location at the Engelmeyer Clinic in Napanee, which is north central Indiana, a rural area south of South Bend. So I will go ahead and dive in here and review just a few things. I have a few slides that are kind of review for the folks who were here 3 months ago, and if you weren't here, it's enough to kind of give you a background about what we're doing and why we made some of the decisions that we made. And then we'll talk a little about how it's going currently and some of the things that we've been learning along the way as we've gotten this project going. So, just again, as a bit of review, Phil and I are at Oaklawn Psychiatric Center. This is a community mental health center in headquarters in Goshen, Indiana, and that's Elkhart County, but also covers the county immediately to the west of us, St. Joseph County, which includes South Bend and Mishawaka, kind of a small eastern suburb, and a couple of other little towns around South Bend as well. Oaklawn provides inpatient as well as outpatient and residential services. We have and have had for several years now an integrated behavioral health program with behavioral health clinicians. If you see the abbreviation BHC in these slides anywhere, that's a behavioral health clinician, and it specifically refers to a licensed clinician, whether it's a licensed social worker or a clinical psychologist. But that's a licensed clinician that is deployed and working in a primary care setting. We have BHCs located in 6 FQHC locations, an FQHC, Federally Qualified Health Center, Safety Net Primary Care Clinic, and a federally funded program to provide clinical medical services in rural and underserved areas. We, of course, at Oaklawn have multiple other contracts and projects as well, but my focus area is in integrated healthcare in collaboration with these clinics that are around our area. We are clinicians, and right now we have 1 psychologist and 3, maybe 4 LCSWs actually. We've added Phil since I made this slide a while back. Are located at several of the clinics around the area. HealthLink, IHC, and Heart City are 3. The one that we just added is IU Health, Goshen Physicians. That's the network around Goshen. As those of you who've worked in primary care, integrated primary care, know, there's a high need for mental health care in primary care. And it's not just a high need, but there's a high variety, and it's kind of a moving target, and it's an interesting and complicated and sometimes frustrating high potential area within primary care, because there are so many medical conditions that have comorbid mental health conditions. There are so many edge cases of mental health, and maybe a non-diagnosable or subsyndromal mental health presentation, but nevertheless it affects a medical condition and the severity and management of a medical condition. And then there are sometimes just behavioral issues where there's no mental health condition per se, but the person's behavior and choices and habits and all of that kind of stuff is impacting their health. And so in all of those areas, mental health clinicians can be helpful. And so there's a high need in primary care, but there's not a lot of availability. It's just hard to find mental health clinicians, let alone mental health clinicians that are comfortable in a primary care setting. And then to make matters even worse, when mental health care is available outside of primary care, so that would be like Oaklawn community mental health center, other mental health centers around the state. Even when mental health care is available, completion rates for referrals are very low. Less than 10% completion of mental health referrals to somebody actually making a connection and going through a course of therapy is very low. I think there are some, I've seen studies where referral rates are higher in the 30 to 40% range, but that's just for an initial contact. So, so all of that to say that there's a high need, but often folks don't get the connection and the care services that they could use in primary care. So as we're trying to go about meeting that need, serving some of those needs, we find out too that physicians vary, primary care clinics and clinic staff vary in what they want. Some clinicians are very alert to primary care mental health needs, to mental health needs in general. Some of them have an excellent ability to diagnose and to keep and to treat folks. Some will diagnose and advise the patient, say, you know, you gotta try this, you gotta try that, or here's a clinician, why don't you go see them, I think it would help. And there is certainly a range of issues in primary care that basically say, you know, it's not my thing, I don't do it, it doesn't seem to be that big a deal, I'm just gonna let it go and not do anything about it. So those choices, those three choices and probably a range of others, we find scattered around the primary care landscape with regard to mental health services and access to them. It's also, as I said before, difficult to get into community mental health treatment, partly because it is a challenge for a mental health center to operate. They operate in such a regulatory framework that anyone who comes for care needs to be run through this whole mill of procedures, just basically an intake, what we can call briefly an intake, but it's, you know, they have to see a clinician and do a diagnosis and be evaluated to whether they're eligible, and there's a whole a chart that needs to be opened and various entries made, and a whole process sort of gets spun up around every patient who comes to a mental health center, and that adds to a lot of overhead. Even though mental health centers, you know, are compensated for the care they provide, and it's not bad compensation, it's just difficult for them to get cases up and operational. And I was just having this conversation yesterday. Somebody said, it's difficult to undertake an intake when you know from the beginning this person's not going to be eligible, because it just, even though the clinician gets paid for that intake, as a center, there are so many people that need long-term care that we try and focus on those people that are going to be with us for a while, and the quick kind of turnaround work just isn't nearly as a good fit for what we do in community mental health. And because of the wide variety of folks that we serve, we're not always the most efficient. So there are multiple barriers to accessing community mental health care. Not that it doesn't work well, and it does for many, many cases, but these are some of the reasons why we want to move out from community mental health and start to place clinicians closer to where patients spend more of their time, closer to where the primary care clinician is, and closer to where they can get help that they need. And the picture is supposed to imply that there are difficulties involved in operating a large community mental health center, like there are in operating a large boat in shallow water. All right. There's a model, and I talked about this a little last time, and I'm not going to go into it much, but Cherokee Health Centers in Tennessee has been working on this. They're a primary care FQHC group of FQHCs, and they have been working at this for a long time, providing integrated mental health care in primary care. And they've developed a model that's called the Cherokee Model. There's nothing magical about it, but it's basically clinicians are housed and officed and work alongside primary care docs. They're very present in the clinic. They expect to work briefly with patients. They expect to be interrupted during sessions. They are constantly consulting, providing brief intermittent therapy, not long-term counseling, but brief topic-focused or problem-focused treatments, maybe many times behaviorally focused treatments, relaxation treatments, or sleep hygiene, or self-care regimens, helping patients learn how to take their meds, how to do their blood testing, to do a lot of things, how to change their behavior in such a way that it supports their health. And one of the key elements of that whole integrated, highly integrated type of a model is the warm handoff, where the doctor will say during the session with a client, with a patient, you know what, I have a colleague down the hall, Phil, who I think could be really helpful. I think he could help you with this problem that you're having with insomnia, or I think he would be really helpful as you're moving through this transition, as your daughter is moving away to college, or as you're working through the loss of this miscarriage, or the troubles in your family, or your high blood pressure. I know you're having trouble taking your meds on time, or all the stresses in whatever. I think that my colleague down the hall could help you. Would you be willing to talk with him? I want to introduce you. And then just walk down the hall, knock on the door and say, hey, Phil, this is Mrs. Jones, or this is Mr. Smith, and I'd like you to see if you could work with them on this or that issue. And that introduction right there can make a referral stick, where in any other case, if they just said, go out to the front desk and I'm going to have the person at the front desk schedule you with Phil, the behavioral health consultant here in the clinic, that can stick sometimes, but a warm handoff is twice as effective. So what the Cherokee folks learned is that whole idea of the sacred therapy hour just does not hold up. You have to be willing to be interrupted. You have to work in close proximity to each other, do brief therapy, and be willing to say, okay, hang on, time out a second, I got to talk to the doctor, I'll be right back. Have your patient just wait. You go out and you talk to the doctor, get your introduction maybe or something else, and then come back and continue working with the patient. So it's a much different model than traditional mental health. And as I said, that key factor is the warm handoff, that you're on site to meet the patient right there. So the easiest way to provide this kind of care is obviously to provide a clinician at every primary care site, somebody there who can cover the clinic and take those warm handoffs and see those patients. But the challenges there are it's really not quite that easy, because there are a lot of clinics that need to be covered, at least in this network, in our particular application. We have 10 clinics we'd like to cover. We don't have enough BHCs to place one at each clinic. There's not enough room at each clinic for every BHC to have an office. It's just not, they have offices for the physicians and they have exam rooms, but they don't have space for every clinician to, take up residence there at the primary care clinic. And then there aren't enough clients to keep a full-time person busy at each clinic. So you're going to deploy full-time resources in the form of a person and an office and all the overhead that goes with it, and then you may not fill up that resource. You may not fully utilize that resource. So for all those reasons, we wanted to do something a little more flexible. And we wondered, of course, having a background in telehealth that I knew that we could do that using some technology to bridge some of these gaps. So what we wanted to do was provide those warm handoffs. So step one, we place a BHC at a primary care site, at least one, to get to know people, to promote access to best quality care, to develop relationships with the primary care providers, to establish a referral pattern and expectations, just to kind of get into the mix there. We also wanted that clinician to be working as a colleague of those primary care clinicians, so that they would share the medical record, that they would share physical space, that those services would be billed out of the primary care clinic. There's a number of reasons why it works best if the clinician's work is part of the primary care office's functioning, both legally and financially, as a records, as a place that records are housed. We didn't want to have an Oaklawn satellite clinic at the primary care clinic, because then it'd be Oaklawn doing billing. Oaklawn would have a separate relationship with the patient that would necessitate all of that overhead and all of that chart stuff that I talked about to be started. So we really wanted to put the clinician there operating as if they are in the primary care office legally and financially and everything else. So we established that. Then we added technology to the mix. This is the little mobile unit that we have. In fact, it's the unit that Phil is joining us on right now. It's fairly simple. It's inexpensive. We can put these together for under a couple $1,000s, sometimes even under $1,000, depending on which components we choose for it. It's mobile. This one doesn't happen to have a battery, but the next one I'll show you does. And so we did that, and this is Phil's office at the primary care clinic. Now they happen to have a space that they could house him, so they set it up. And as you can see on the right side, this is from the hallway. You can looking into the clinic. That's what's there right now. And actually, off to Phil's left in the picture is he's got his own laptop operating, and he's monitoring this room as we're talking here in case a doctor or a nurse walks in there with a patient and says, hey, Phil, we need to do a handoff. So that's what's happening at the primary clinic right now. And you can see that with that technology, then Phil can be there and where he is now, the other clinic location where he's at, or the other office at the same time. And with that allows for, this is the room where Phil is now at the Oaklawn remote office. So with that technology and a little bit of logistics, we can make this happen. So the logistical part is this, that the BHC, the clinician, is on site some days and off site other days, obviously, but they're available for handoffs all the time. Whether they're there or whether they're remote, we make it possible for a doctor or nurse to bring a patient in and say, hey, Phil, just like they would if he were sitting there in the office. They knock on the door and he comes out and can make an introduction there. Now, he can schedule follow-ups at whatever clinic and whatever time is convenient for the patient. So they can go to their local primary care clinic any day of the week, and whether Phil's on site or off site, he can see them there, because if he's off site, he'll do it remote, by video. And if he's there, of course, he'll see them in the office there. There are a few more complexities to it than that, and obviously people need to get used to the process. But that's our vision and that's our goal, and so far we are a fair way into it and doing pretty well. We are implementing, as I said, the same basic Cherokee model of interruptible mental health care on site. And the way we do that is, as I said, the video system's always running, and the nurse and doctor can walk into the office anytime and just say, hey, Phil, whatever he's doing, he puts on hold. In fact, just before this webinar started, he had a handoff, and he said, hey, Becky, Jonathan, I got to take this. So put us on hold and went and took a clinic, or took a handoff. And then when that handoff is done, then he can return to the previous patient if necessary. I'm sorry, I'm talking right past him. It's as if I'm talking about somebody who's in the room, but Phil's going to tell us a little more about it in just a second. So sorry about the appearance of being impolite, but Phil's going to chime in just a second when we get to the story part. Maybe, actually, you know what I'm going to do is I'm going to stop right here because I'm thinking about it. And Phil, give us just, maybe don't tell the warm handoff story, but give us just a sense of what it's like to bounce around from site to site. You're going to have to unmute yourself, or maybe Becky can unmute you. But give us just a sense of what it's like to operate virtually in multiple sites.
Okay, let me just take care of that mute. And I think Becky has to unmute me.
No, you're on. We can hear you.
Okay, great. Well, it's interesting in that I have a couple of laptops that I carry around with me. So packing up the agency, the PCP's laptop, which allows me access to their electronic health records, as well as the Oaklawn laptop, which has the Zoom hardware and allows me to access Oaklawn records. So I have two separate devices for accessing two different ECRs, and they have to be kept separately for security reasons. So I get used to doing a little weightlifting and carry these laptops from office to office on those nights that I do transitions. But it's fairly simple, just plugging a few things in. It takes me maybe 5-10 minutes to set things up, and it's actually very simple. As long as hardware and software are cooperating, it's very easy. And I haven't had any significant difficulties at this point in time. It's just getting used to whatever devices are in front of me. So go ahead.
Yeah, no, great, thanks.
Yeah.
So yeah, and I want to get an example, and in a few minutes we're going to hear from Phil on a specific example that I thought was particularly interesting about the handoff process. So I think I just have a couple more slides, and then we want to talk a little bit more about what's been going on in the clinic. This slide is kind of underscoring what I've already said, but I think it's worth saying why we do it this way. It's in some ways it could seem a little more complicated, but what we're really after is that the doctor not have to think about whether Phil's on site or not. It was remarkable to us when we started this how much the doctors thought about what day of the week it was and when's Phil here and when's he not here. And I realized that most of the doctors only work 4 days out of the week at this particular clinic. And so there are days when Dr. X is here and Dr. Y is here, and she's only here a few days. And these days they have the schedule that they're used to thinking around. Who's here when, and when can I make a referral and when can I not? And we really didn't want them to think about, okay, it's Wednesday, so I can't refer to Phil. We wanted them to, regardless of where he was, to just say, go down to the room and we will find a way to for Phil to talk to you. So that's really what we're after here, so that they don't have to know that. And it was a little bit counterintuitive, but they picked it up after a while. So far, we are experiencing, just wanted to give you an idea of our numbers here. In the month of May, the first month that we went live, Phil had 16 encounters. There were 24 scheduled and then 8 no-shows. So it's still a fairly high no-show rate or reschedule rate, whatever. In the month of June, Phil had to be gone for a week, so that, and those were scheduled. It was kind of an emergency, and he had scheduled patients that we had to kick off the schedule and reschedule for another time, so that really disrupted encounters in June. Just nothing that could be done about that. And then in July, we're back up to 17 encounters out of 25. So that's kind of the pace that we're at this point. Obviously, we have a whole lot more capacity than that. And over the next 3 months, that's what we're looking for, is to have those physicians start to utilize the capacity at a higher rate. Phil's also spending 1 day a week devoted only to video, so that they get used to that video experience, and Phil can work out any bugs related to the video. Almost all the referrals that we've had so far have been appropriate. I mean, they're great cases for an integrated primary care clinician. Most of the clients report benefit or satisfaction. You know, they have a high level of satisfaction, although we haven't looked at specific objective rating scores. The patients rate, the clinic uses a rating system, you know, for satisfaction, just like any other patient there. We don't have a separate rating system to measure it. And nobody's reported any discomfort with the process or technology. The staff have been fantastic about taking it on, and the doctors and patients have adjusted very rapidly to it as well, and which you'll hear more about from Phil. So let's talk a little about the handoff experience, Phil, because we had some questions early on. How smoothly is this going to go with the doctors? How easy is this going to be? And so tell us a little about an experience or two you've had with a handoff.
Well, actually, it's kind of amusing to me, because the first day I was here, I actually had a handoff within like half an hour of starting things up, and the physician simply knew that I wasn't present, could see from the hallway that the telehealth device was on and that I was in the room, or that there was a room open. And so he just walked in, called out my name. I said, "Have a seat on the couch," and he sat down, and I could see his face. And he said, is this how we do a handoff? And I said, absolutely. And what do you have going? And he just launched right into talking about what was going on with the patient. There were no ifs, ands, or buts about the technology. It was just the fact that he was there and I was here, and there was a device in between us. So it was as if we were virtually present, I mean, literally present with each other. And so it went very, very smoothly. And the patient and the attending adult came in. They both sat down. They both giggled a little bit. They hadn't been through something like this before, but very quickly relaxed. Spoke easily to me, and I could easily communicate with them. And we were able to get a little bit of information. I was able to schedule them. And next week I saw them, and actually it was the next day I saw them live in the office. So that was about as smooth as I could have possibly asked for a first form handoff.
That's fantastic.
And the one that just happened right before this webinar was exactly the same thing. Same physician came in, just had to unmute myself, kind of pull myself away from this to the other screen. And again, a patient and their mother came in, and I told them about the device. We all laughed about it, and acted as if we could exchange information through the screen, and had some good laughs, and got down to business and got them scheduled, and be seeing them next week. So
excellent.
Yeah.
See, one of the things that that I think clinicians debate a little bit, and we wanted to test out, is that the idea of a warm handoff implies, right, that you're touching, that you shake hands, that you are, your body heat is close enough that you can feel it. And it's not, and we wanted to know, can we recreate that experience? Can we recreate the introduction, the beginning of developing a clinical relationship, which is all about making a patient comfortable with you and making them comfortable with the situation such that they would say, oh, yeah, okay, I can do this. I can come in next week. I can come in tomorrow. I can talk to you. You seem like a decent person. That's the experience that we hypothesized was key, and not the handshake per se. They don't need to smell my cologne or see me up close and personal. We can do that. We can start building a relationship virtually. And that's, I think, been Phil's experience so far, is that technology, as long as it does what we're expecting it to do, doesn't get in the way of that. It's a little different, and we have to adjust a little bit, but it doesn't get in the way.
Yeah.
Okay, so what about the clinical experience? So there's Phil on the screen. This is what a patient would see, although that one is a self view, so they're seeing him sitting on the couch there, but they would see the picture that you're seeing now, well, something like it, about 90 degrees off. But talk a little about some of the clinical experiences you've had, Phil.
Sure. Well, actually, later on today, I'm scheduled to see 2 patients by telehealth or telemedicine device. And I have a patient who I've seen in my office off and on since I started there, and their schedule shifted in such a way that it wasn't convenient for them to come into the office on the days that I was present. I didn't have availability, but I did have availability by telehealth, and they were able to show up for the experience. And I'd say within 30 seconds, everything was fine, as if we were both present in the same room. She came in, sat down, we laughed a little bit, kind of got used to the idea of talking to the device, and then just right down to business, as if there wasn't any problem. And I think that's largely responsible to the fact that due to the advances in technology, next to no lag in communication, reasonable high-resolution screens giving fairly lifelike representation, not very little skipping or pixelation of the screen. So the patient and I are able to have a relatively relaxed conversation. It just happens to be the fact that we're miles and miles away from each other and doing it virtually. So it was I had no problem as a clinician doing it, and I think the patients had no problem doing it either. So.
Yeah, that's great. That's another key thing that we're shooting for in this whole project, is that we want to replicate the in-person process as much as possible. I have a bullet point on that in the next slide. I think we want the not only the patient, but also the referring physician, the nurse, or the medical assistant, or whoever else, anyone who's involved. We want that telemedicine device to, in a sense, be Phil's presence there. So whatever you would do to walk up and talk to Phil, or knock on the door and interrupt Phil, or whatever, we can do that virtually, that we're using that technology to provide that in a way that's more like walking up to a person on the street than it is like, walking into the office of the Wizard of Oz in the Emerald City, where you have to be ushered in, there's big doors, and there's, a big screen and smoke and mirrors and everything. We're trying to normalize the interaction, the process of seeing somebody over video, so that it's more like walking up to a window and talking to somebody through the window, and the window just happens to be in the office where you normally would come. So, so one of the things that we've learned is that, like any integrated primary care process, services start up slowly. Providers are having to develop comfort with Phil, what he does, how he can help them, which of their patients would be good for him to see. And this is just standard stuff, regardless of telemedicine. This is what happens in primary care when clinicians who haven't had access to mental health services all of a sudden have a mental health person on site. They're figuring out how to change their behavior such that a steady stream of people start getting sent to Phil, and they start thinking in the clinical setting, here's a person, I bet you would benefit from Phil, let me introduce you. Because that's hasn't been part of their mental process until now. And oh my goodness, talk about algorithmic thinkers, or people who think in a pattern fast. It's physicians. They just have patterns that they work through, and it makes them very efficient at what they do. But then if you're going to add a new chink, a new pathway, a new choice in that pattern, it sometimes takes a while to get them to interrupt what they're doing and say, wait, consider this other option. So we're developing ways of putting sticky notes on charts and having alerts come up in the EMR, and other ways that we can alert them to the fact that, hey, this might be a good referral. The second thing that we've learned, and I think this is really sort of a success point, I think something that we can be proud of, is that adding video, as you heard from Phil, is almost a non-issue as long as it's working, as long as it does what it's supposed to. Now, obviously, those are it's a big if, and that's kind of, people would say, yeah, sure, any technology is great as long as it's working. But that I think parses out, in our minds at least, the idea of whether the technology is working, which of course it needs to work consistently, from whether the technology per se changes things significantly. And in our experience, it can be arranged, things can be arranged such that the technology does not change things significantly, that you can do what you do normally, but you can do it at a tremendous distance, or whatever arbitrary distance, whatever distance it needs to be, using technology, as long as it's a well-designed process that integrates well. And my goodness, the nurses and the doctors have really picked it up. I noticed, Phil, even this morning, or was it the other day, you had to get somebody on the phone and say, hey, I think the unit's not on. Would you go in and turn it on? And they know the procedure to go in and just flip it on.
Yeah.
And then we had also talked about, I remember we came to that because we were thinking, should we have the doctor come in and turn the thing on to introduce somebody? And we realized that was too big a barrier. We wanted it to be just on all the time, and the bandwidth is paid for already, so we're not paying by the minute. So do you think that having the video on all the time has made a big difference?
Yeah, it's just instant availability. I mean, I'm still kind of getting used to being in an office with that there and just being ready to respond. That's the only thing. I think that's the unique thing for me, is that nobody comes knocking on my door or the telephone doesn't ring. Suddenly somebody's there. So if you have to think of it as your door is always open, if you're in an office waiting for a warm handoff, you could be reading, studying, doing something else online. And as long as you kind of remember, what do I need to do to be available when they walk in the room and they start talking to me? So it's little cues like, please have a seat so I can see your face. Oh, otherwise I'm talking to a torso, because there's that in front of the device. And a reminder to me that, oh, I need to unmute my mic so they're not hearing background conversations in my office. Mm-hmm. So little things like that. But generally everybody's been very patient, and the handoffs have gone really well. At that handoff, actually, that just ended this morning, I'll just say it was with a teen and that teen's mom. I heard, because we were all laughing about the technology and while we were having the conversation, as the teen was walking out, I overheard them saying to their mom, "That was hilarious," in a good way, in a good way. So I'm looking forward to actually seeing that person live.
Well, it's interesting. There's a lot of research that's done around telehealth, and it is something that has started to kind of become well known around the telehealth world. Is that generationally, this is very rapidly accepted by kids, rapidly accepted by a younger generation. When I started in this field, I would ask people, how many of you have ever been on a video call? And I'd get a room of 100 people and 2 or 3 hands maybe. And now if I ask how many have not been on a video call, it would be the same, because there has been such a sea change in our familiarity with and acceptance of video. Couple more things that we would recommend going forward, and I've probably said all these already, so it's not going to surprise you that much, but simple and familiar procedures. That makes, I believe, all the difference in acceptance, because if somebody had to come in, I mean, it would be possible, certainly possible, to teach someone to come in and pick up a remote and push some buttons and choose this and that and the other, and it has to happen many times. But we really were looking for what's the absolute minimum that we're going to ask of our providers to refer, and the ability to just say, hey, walk in the room and say, hey, Phil. That's what they would do anyway, although they might knock first or whatever. But that's the bare bones minimum of a requirement, and we're going to figure out a way to work around that so that we can accommodate that as the referral process, and everything else happens the way it happens. We also worked and are continuing to work at making video a familiar part of the culture. Rather than walking into the Wizard of Oz's office, it's more like just another way to talk. It's like the telephone, picking up the phone, sitting down in front of a screen and talking to Phil and saying, hey, I got a patient. It's just like that. It's the next telephone. And so to do that, we did a lot of things other than clinical. We have our supervision meetings sometimes over video. We've had planning meetings with the folks from the clinic. We've had lots of different other events and meetings by video, just so that we all know what we're talking about. When we say video, when we say live video, we know exactly what that looks like. And we think that's important for all of the people involved to have that kind of experience. And it really does lower the anxiety factor when a medical assistant or even a doctor can walk in and sit down and just start talking and say, hey, here's the patient, and introduce the patient. That sends a totally different message than if the doctor walks in and says, okay, where's that remote? I'm not sure if this is going to work, but let me see what I can do here. Then the patient is wondering what's happening too. And it's just, we want to portray that confidence that, hey, we know what we're doing. We've done this 100 times. It works fine. It's great. It'll be easy. Phil's great. Talk to him. He'll help you out. And that's the message that we want to be sure and portray both in our actions and our words. And we've worked a little with the staff on making sure that that's how they feel and that's what they say when they're working with us. I don't think I have to work too hard to convince those on this call that we think the video format has tremendous potential. I mean, think about if traveling and location was out of the picture and you could show up anywhere at any time. We know that it's important when we do a video service, when we implement a new video service, that the existing needs and wants of the folks who are getting the service are really what's fundamental. If we come in and say, hey, we want to have a clinician come in by video, what have you got for him? You know, that kind of puts the cart before the horse. It's not about the video. It's that we want to build an integrated primary care service, and we want to do it in the most efficient way. In order to do that, we're going to leverage some technology to make that happen. And we're going to leverage the technology in such a way that we don't introduce a Byzantine process that takes 2 technicians and a half an hour to make happen. We want it to be simple and straightforward, but the whole reason we're doing this is so that you can have integrated on-site mental health care. That's the reason we're doing it. It's not because we want to play with toys. At least we try and make sure that that's not the reason, not the main reason. And making the process simple and familiar is a component of empowering the local staff. Obviously, empowering the local staff is a big deal. It's paramount to success. And we believe that making the process simple is a way of empowering them so that they know intuitively. How do you talk to Phil on video? You sit down on the couch and you say, hi, Phil, and away you go. So, Phil, you want to add anything? I think that's all I have as far as content.
There's no one set specific protocol. I would simply say that just view everything as guidelines and work with whomever you have to work with on what works for them. It's very simple. Initially, I think we had all sorts of ideas about structure, and then we just kind of had to relax and just see what came naturally to folks. And when we did that, it just got easier. And when we actually got live, again, it just was a non-issue. Just like negotiating any type of conversation or protocol with somebody else. There it was. And so it's just an ever-evolving process as new staff come in. And it's just like, again, in any other natural evolution of a process or a relationship. It's nothing magical.
That's so key, and I'm glad you said it that way, because when we first started, and like I say, we've been at this for a year and a half. Phil's been doing it for a few months here, but we've been at this with the Goshen Hospital and healthcare group for over a year and a half. And at several points, people wanted to know, okay, so how do you do this, or how are we going to do that? What's the procedure for this, and what's the procedure for that? And I felt bad because I kept saying, it'll come. We'll figure. It'll be whatever the staff wants it, or we'll figure it out, or that we can do that once we understand how the primary care office works. We didn't say it needs to be this way. Do this first. Do this second. Do this third. And I think your experience, Phil, has borne that out in that. We got bright people. They know that these patients need to be seen by these clinicians, and we've got tools to make that happen, and they will figure out how to make that happen. Now, it's not to say, you throw the playbook out the window, but it is to say that when you make connection simple and intuitive, people will figure out what's the most efficient way to do that, or what's the way that fits within the process as it exists. And so we've certainly seen that happen.
Absolutely.
All right. Well, I put my contact information on here because Phil is busy a lot of the time, and if you want to talk to him, you certainly can. And I can put you in touch with Phil directly, but this is the slide that I had from last time. Feel free to contact me, follow up if you have questions. And if you lose this information, Becky can always find me. we've been working together for a long time. So we want to leave whatever time is left. Looks like we got a few minutes. If there are questions, I will, well, I'll leave this slide up there. You can see us and you can see my contact information. But if there are questions, we would love to have them. Go ahead and type them in the Q&A window.
Yeah, this is Becky again. Thank you, Jonathan and Phil, for being with us today. I really appreciate it. It's fascinating to hear the beginning of this journey, and I wish you continued success.
Thank you.
So as Jonathan said, now is the time for questions. If anyone wants to put anything in the chat window for questions. I know I'll start with one. So here in the state of Indiana, we had an interesting law take effect regarding telemedicine prescriptions and prescribing on July 1st of this year. And Jonathan and I have had some discussions about that. Phil, what's your take on this new prescribing law, and how has it affected this particular practice?
It doesn't affect me at all because I don't, prescribe medication. So I'm providing a mental health service. I'm not a physician, so I don't have to worry about that at all. Not on my plate.
It is interesting, though. Not interesting isn't the right word, but Oaklawn, as an organization, has lost 2 child psychiatrists over it because of the confusion. One resigned pretty quickly, and the other one just recently resigned just because of ongoing concerns about what that law actually means and how the medical board is going to respond to it. So, so yeah, it's not insignificant in the larger picture. But as Phil said, we're providing a service that is pretty straightforward and doesn't get impacted. In fact, both the psychology board and the social work board here in Indiana don't say anything about telehealth, telemedicine, and so we're doing our best to be responsible clinicians. We have our codes of ethics and good practice certainly say an awful lot about how we do our work and how we make sure that patients are not harmed and are being helped and that we're serving them appropriately. And all of those rules still apply because, as we've been saying all the way through, this is the same service that we would provide if we were in person, and we're under the same laws that we would be if we were in person, and we're just using technology to stretch the distance a little bit.
Okay. I don't see any other questions in the Q&A. We'll give it another minute or so. Just some housekeeping information. As a reminder, we will get the slides out and get the link to the recording out on our YouTube page here in the next week. And thank you for joining us today.
Wow. Okay. Great. Well, follow up if you think of something. And thanks for having us, Becky. This has been great.
Absolutely. Thank you very much.
Mm-hmm.